years and years and years of pharmacology and not really have a big clue about what's going to happen to your patient. So it's really combining the two. Pharmacology is absolutely essential for therapeutics. So it's a term, and I know when I was doing the La Trobe courses in podiatry, I had I think I did manage to get the name changed to therapeutics, because that's what it really is. Okay, so just before I move on to the topic, I'd just like to bring this to your attention. I've been involved with what was originally the Victorian College of Pharmacy, and then later on became the Faculty of Pharmacy and Pharmaceutical Sciences in Parkville. For those of you who are in Melbourne, you know what that is. It was a tin-pot little college when I started, and now, interestingly enough, there is a worldwide organisation that looks at the ranking of universities right around the world. And when it comes to Monash University, we're about number 53, which is considered very good. Melbourne's about number 35, which is better. I don't think any other Australian university is within that range. But when it comes to individual doctrines, and this is called pharmacy and pharmacology, for the first time this year, we are number 1. Last year we were number 2, and the last 10 years, that's me, we've been in the top 5. Which is quite an amazing achievement. Now, the sad bit about that, I'll just show the next slide, which, oh, I'm right in front of it, I'm sorry. Okay, Monash University, world's best, number 1 for pharmacy and pharmacology, QS rankings, globally in the QS, and think of any university in the world, we're above them in that area. There is no other university in the country that has been number 1 in any subject before. That's not bad. No other, it is not bad, not bad. Now, I had my little input, but only very little input. There's people much better than me. I've been officially retired from there for some years, but...
Founding father, Louis.
Sorry?
Founding father. Founding father.
Well, so almost. And so I still talk in terms of we, you know, how people refer to themselves in a football team, we. I refer to this as we. And it's not bad. What really, excuse the language, what really pissed me off, there was a tiny little article in The Age about it, about page 9. Now, had this been a sporting event, it would be splashed on the front page and pages and pages. Now, I think in this country we do not appreciate our science. We do not appreciate education. It is really, really sad, because this is something that's quite unbelievable, that this little place, which would go from 1 building, we now have 6 buildings and all sorts of international interactions, top ratings for satisfaction by students. And I don't know if you read, those of you who read The Age today, there was an article about universities going down in student ranking, but Monash overall is better than Melbourne, but they didn't talk about individual faculty. So we are lucky having our faculty separated from the Monash in Clayton, which is the parent one. Okay, I just couldn't help myself. I had to tell you about that, because it's a position of a thing of pride for myself. So this is, it's hard to take all the buildings together, and there it is there. Okay, so let's move on now. So what we're going to deal with today is, and I think there's notes, you've probably got them on your computer, yep. We're going to look at pain, then we're going to look at corticosteroids for pain relief, that's additional to, if you like, anticoagulants, a review of that because it's a pretty important new area, and anti-infectives, or mostly antibacterial, but with just a couple of words on COVID, and antivirals. Now, as you know, for the last 2 years, we've done this on Zoom, and the last 2 years I've talked about COVID. The first one was the possibility of vaccines, you remember, and of course we've got the vaccine. And then the next one was to do with the problems associated, or perceived problems associated with the vaccine. And of course, the way that the press has handled it has really been disgusting, because basically creating panic unnecessarily. Anyway, well, just a few words on that. And then I predicted at the time, even the very first one, that COVID to some extent can be viewed a little bit like HIV, where in the case of HIV, we still don't have vaccines, but we do have very potent drugs that attack the viral pathways. And we have a similar thing now with anti-COVID, antiviral drugs. Well, that's probably all I need to say about that. So let's now look at the objectives. So at the end of this session, with appropriate follow-up, attendees should be able to discuss the various aspects of drugs used and the role of the podiatrist surgeon in the treatment of pain, corticosteroid and so on. They're basically listing. So let's look, well, that's a nice one. Oh, sorry, I hate it when it does that.
There's a dog barking. There's a dog out there.
Sorry about that. Okay, I think as one of the things, as the health professions that you're involved under APRA, as people from New Zealand, anyone from New Zealand here? No, no one from New Zealand today. We all operate under APRA. Of course, yours is podiatry and mine's pharmacy. And of course, they require for health professionals to have access to appropriate references, be they electronic or hard copy, doesn't matter, whatever suits you. I tend to have both. So the therapeutic guidelines, absolutely important. You're all aware of the therapeutic guidelines, I would think. And they are absolutely important because this is about medicines or drugs and which drugs to use for which condition, how much, how often, and for how long. That's the basis of it. And of course, there's a whole lot of different therapeutic guidelines. And now you can't get hard copy anymore, it's all online. EMIMS, which is pretty useful. The Australian Medicines Handbook, I think between that and therapeutic guidelines, that's the absolute must. And that comes out every year, the Australian Medicines Handbook. I've got both hard copy and online. And sometimes I've got the hard copy open and the online open at the same time. Then for basic pharmacology, which of course is a little bit extended, we've got Bryant, Knight, Derrick and Rowland, Pharmacology for Health Professions, 5th edition. And this, Bronwyn Bryant is an ex-colleague of mine. She originally was a pharmacist and then a PhD in pharmacology. And this is the 5th edition that they've written of this pharmacology for health professionals. And it really is a very, very good, and it's relatively up to date, 2019. And I've got hard copy of that one. Rang, Citron Flower and Errol, Adele's Pharmacology, this is a British one. Also good, if you prefer, just as good. Neil, Medical Pharmacology at a Glance, the 9th edition, which came out in 2020. That's a much slimmer version. And if you want a basic refreshment, if you like, that's worth getting. I don't know if you can get it online, but I certainly have it on hard copy. It's about that. Each topic is a double page. And it shows you the areas that we're talking about and then the particular drugs that are used and so on, with not a great amount of information, but enough to re-stimulate you if you think your basic pharmacology has gone down. And then you can graduate to one of the more... Now, there's lots of pharmacology texts. I think the important things with any of these is that they've got to be the most recent. The Pharmacy Board of Australia, and I think the Podiatry Board does the same because I was involved with what they were recommending, which texts and so on, and that they should be the latest editions of, and that you should have access to these things. Okay, so let's look at pain. This is a fairly jolly slide. So, absolute morality is the regulation of conduct in such a way that pain shall not be inflicted. This is Herbert Spencer, an American physician back in 1891. We've known about pain forever. People don't like pain, and we live with pain. Then this one is, for all the happiness humankind can gain is not in pleasure, but in rest from pain. And this was the Indian Emperor, John Dryden, it's a play back in 1665. Many older people will come to see you, or you might come to see them in hospitals with podiatric problems, requiring surgical procedures in your case and others. And of course, as you know, we're all getting older. We're more than 2 years older since we met face to face. Think of that, more than 2 years, we're getting on to 2.5 years. Because the last 2 years I've been doing Zoom with you, and it's not quite the same, is it? So we are getting older. I'm getting quite doddery. I had the big 8-0 not all that long ago.
I need you to stand just a bit closer.
Closer there?
Yeah,
Okay,
there you
okay. Thank you. The camera. Okay. So older people are much more likely to suffer pain than younger people. And pain can come from any part of the body, of course, including the foot area. Acute pain has a prevalence of approximately 5% across all age groups, whereas the prevalence of chronic pain increases with age. And the prevalence of chronic pain in residents of aged care facilities. Do any of you visit aged care facilities? No, they come to you. Yeah, some, yeah, a few. and maybe as high as 86% with pain, often unrecognised and therefore untreated. I think this is one of the big issues that I'll be bringing up here about not being able to know that this person is in pain because they can't communicate it. And how do we handle that? Two major risk factors for untreated pain include older age and the presence of cognitive impairment, the dreaded Alzheimer's, if you like. Psychological, social and spiritual factors may modify the experience of pain and are important in assessment and management. An integrated multidisciplinary approach to treatment is recommended, particularly for pain, and we have pain clinics. Patient-resident involvement in the initial and continuing assessment of their pain and response to treatment is necessary, but not reliable in people with dementia. And of course, there is an increased rate of dementia. We live longer. I mean, just because you're old doesn't mean you're going to get it. It is a disease, but it's much more common in older people, as you know. There was a Royal Commission into aged care quality and safety, and we're now getting into the era of more Royal Commissions and a whole range of things with the change in government. But this one, actually the final submission came out in 2019. So following the Royal Commission to Aged Care, they basically came out lots of things that the concern is appropriate use of analgesics and the overuse or underuse in population, the older population. The big problem is a lot of people are either not treated for the pain because the health professional is not aware they've got pain, or they're undertreated for the pain, and many doctors, certainly in the past, were really frightened to use opiates because they felt addiction, opiates equals addiction. And so they tended to underdose. And that is the problem, so it wasn't controlling the pain. So analgesics, the other one is the extent of poor clinical care includes overprescribing of antipsychotic agents as first-line treatment for behaviour, psychological symptoms, and not necessarily to do with pain, but that was part of a very important aspect. In home, when we do medicine reviews, both in hospitals or at home, so many people are taking antipsychotics. There were some big studies in the United States that showed quite clearly that people in these homes who were taking antipsychotics were much more likely to die younger than people who are not taking the antipsychotics, the effect on the heart in particular. Undertreatment of respiratory conditions is another problem in another area, but we obviously want pain. So barriers to effective pain management in ACFs include patient beliefs and attitudes towards pain, communication deficits, cognitive impairment, frailty, comorbidities, as well as age-related drug response profiles that may affect pharmacotherapy. An analysis of 29, this is an Australian study, looking at ACFs, as aged care facilities, over a 2-year period showed that 90% of residents had regular analgesic orders, with 26% prescribed regular opioids. Now that may or may not be a bad thing, that's just a straight statistic. Defining pain, so then it's defined by the International Association of the Study of Pain as an unpleasant sense. I think unpleasant is really, it's a very British, isn't it? It's very understated, unpleasant. Bloody hell, it hurts. I guess unpleasant covers it. Unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Superficial somatic pain is hot, sharp and stinging, whereas deep and visceral pain may be dull, aching, ignoring. There's lots of ways to define pain. When you're talking to the patient, when they say, I've got pain, can you please describe your pain? Nociceptive pain arises from actual or threatened damage. Okay. Threatened damage or non-neural tissues, and is due to the activation of nociceptors or receptors in the skin, deep tissues that are sensitive to potentially noxious stimuli. Pain is a subjective phenomenon that is present when the person who is experiencing says that it is. I've got pain, therefore I expect you to believe that I've got pain, because sometimes that's ignored. The person reporting personal discomfort or pain is the most reliable source of information about its location, quality, intensity, onset, precipitating or aggravating factors, and measures that bring relief. And pain is what the patient says hurts. That's probably the easiest definition. What the patient says, it hurts. what the patient describes and not what others think it ought to be. So we can put on all our scholarly hats on and put all our degrees up, but that person is the one who can describe the pain to you. You can't describe their pain. None of us can put ourselves into the other person's and say, I've got that quanta of pain that this person got, because there's no such thing as a quanta of pain. And of course, you know the pain pathways. And of course, I took an example with a foot, obviously, and you've got the pain, and ultimately, the brain registers it. That's what registers the pain, is the brain. I'm sure you know all about that. Pain types. Pain may be classified clinically as nociceptive. That's activation of normal pain fibers in response to a noxious stimuli, an injury, disease, inflammation. It may be somatic, involving superficial structures such as skin and muscle, or visceral, such as involving deep organs such as liver and pancreas. Now, I know you're not dealing in those areas, but this is an overview of pain. It's not just podiatric. Neuropathic pain, injury or disease affecting the peripheral, such as diabetic neuropathies, phantom limb, or central, such as spinal cord injury, post-stroke, nervous system, or both, such as post-herpetic neuralgia. Shingles. Have you dealt with any patients with shingles? Yeah. The pain is excruciating along the body and all various parts. Mixed nociceptive neuropathic pain, such as some cancer-related pain. So it's important to distinguish between nociceptive and neuropathic pain, as they respond differently to drugs and other treatments. So pain types, so I've got some drugs along the side, or drug groups. Acute pain or nociceptive, and then chronic pain. I think we've got, yep. Neuropathic pain along there and chronic pain down here. So paracetamol. If you're in America, of course, they don't know what paracetamol is because it's acetaminophen. They don't know. I was lecturing to 6-year pharmacy students some years ago on a sabbatical, and I mentioned paracetamol, and somebody put their hand, Professor, is that a new drug? And I said, oh, so sorry. Acetaminophen. Why did you say so? Well, the rest of the world tends to use paracetamol, and we are aware that there's different names for it, but in the United States they're not aware, which is quite interesting. Well, what can you expect? They still use the imperial system of weights and measures. And they had Donald Trump. So paracetamol in acute pain can be effective. I mean, it's not going to, it depends on the intensity of the pain, but it will certainly ameliorate the effect. Neuropathic pain, paracetamol is less effective. In chronic pain, it can be effective. When we say effective, it doesn't mean it gets rid of the pain altogether. I think the other issue with pain is that some people have to learn that they're not going to be able to be totally pain-free. It's a matter of what the individual can tolerate. Non-steroidal anti-inflammatory drugs, they tend to be effective in acute pain, less effective in neuropathic pain, and they're quite effective in chronic pain. Antidepressants, such as tricyclics, are rarely used for acute pain, and it'd be pretty useless, but may be effective as first-line treatment of neuropathic pain. Now, tricyclic antidepressants are not a particularly wonderful thing to use in older people, because they tend, all the side effects that you get for the anticholinergic side effects can be very unpleasant. People can fall, they get dizzy, their vision changes, and a whole range of things that I'm sure you know about tricyclics. And may be also effective in neuropathic component. Now, anti-epileptics such as gabapentin, pregabalin, and carbamazepine are rarely used for acute pain because it's not going to have any great effect, but except for all the side effects. Neuropathic pain may be effective in some cases first-line treatment, and again in chronic pain may be effective if there is a neuropathic component. Then of course we've got the opioids. The opioids are obviously very effective in acute pain. They're the most effective. Neuropathic pain may be effective as second line but not first line, and in chronic pain may be effective but limited or no benefit greater than 90 days treatment for non-cancer pain. So you probably don't want your patient to be on an opioid for 90 days. And not that you can prescribe for 90 days, you've only got, it's one lot, isn't it? Yeah, of one. Okay, acute pain then is a type of pain that typically lasts less than 3 to 6 months, or sometimes it only might last a day, but it's a very short time, that is directly related to soft tissue damage, such as a sprained ankle or paper cut. And it's distinct from chronic pain and is relatively more sharp and severe. And the beauty about it, the beauty about it is if I put my hand on a hot stove, I'll go, ouch, and it's taken virtually no time to get to the brain and then come out of my mouth to say, ouch, that I perceive the pain. So pain is perception. So it's the brain's perception of the pain. And that will hurt, and it might hurt for quite some time because I didn't feel the pain at first and it caused tissue damage. But I know that that is going to get better. Therefore, the level of anxiety is not particularly high. That's an important concept we'll come to in a bit. So what are the causes of acute pain? You've got cutaneous one, or skin acute pain, skin, repeat injury, non-healing skin ulcers, somatic or the muscle acute pain, inflammation, infection and abscesses, inflammation of joint and bone, sprains, trauma soft tissues, laceration of peristeum, trauma bones of joint, disease of muscle tendon. Visceral or acute pain, obstructions, inflammation, and ischemic. Now, I took that slide, as you can see, American spelling, for which I apologise. Some of these things can be really, really severe, of course. You know, you think of car accidents and the terrible damage that occurs to people. If you're living in Ukraine at the moment, people suffering massive injuries from bombs and shrapnel and buildings falling on them and so on. A terrible situation. So acute pain is temporary and usually brief. It's generally of nociceptive origin, serving a positive biological function, drawing attention to the illness or injury, stimulating response to prevent further injury. When I go, ouch, and remove my finger, I've done something because my brain tells me that hurts. The immediate response may be behavioral, such as withdrawal, protective or rest, autonomic, such as pallor, sweating, tachycardia, tremor. It usually settles over time with or without symptom management or treatment of the underlying cause of the pain, or you may take something. Tolerance of pain varies between individuals depending on duration, context, experience, and culture. I have to share this with you. I don't think I have in the past. Many, many years ago in New York, there was a very large study that was carried out about the perception of pain. And what they did, it was a very, very long study. It was absolutely beautiful. And they took 3 groups of New Yorkers. They took a group of Irish New Yorkers. As you know, a lot of Irish went to the United States. Then they took a group of Italian New Yorkers. And then they took a group of Jewish New Yorkers. So the summing up of the pain situation was the Irish would say, doesn't hurt a bit. Just put it, just put a Band-Aid on. Just put my arm back on and stick it up and it'll be fine. It'll be fine, doesn't hurt. I'm exaggerating, but I'm trying to get the message. The Italians, because, well, firstly, with the Irish, the culture is that you be a man. You don't reflect the pain. In the Italian culture, it hurts, stop the pain. And that's perfectly culturally acceptable within that particular culture. In the Jewish culture, it hurts, it's cancer. So there's thought, insight into it, thinking, and of course, if you're going to choose the reason, it's got to be something good. I mean, it's no good saying just a headache. No, it's cancer. But it's over. I'm just trying to show you the differences between cultures. And of course, that's only 3. There's hundreds and hundreds of different cultures around. And so it really is an individual thing, but it's very strongly culturally affected. People tolerate and distract from acute pain until they regard it as a sufficient threat to their normal activities to warrant seeking help. Unrelieved acute pain is associated with an increased risk of myocardial infarct, pneumonia, DVT, pressure sores, and delirium. So it's quite, so if you've got a lot of pain and you just live with it, the chances are you may not live all that long. In some cases, acute pain does not abate, leading to chronic or persistent pain. The term now is persistent pain rather than chronic pain. They keep changing terms just to keep us thinking, not that it matters, if the disease process responsible does not resolve. Other factors that favour continuation of pain and difficulty tolerating it include inadequate initial pain relief, neuropathic pain such as herpes zoster, psychological factors, inappropriate treatment, comorbidities, preventing of effective treatment, and refusal of treatment. When you think of the social implications, and I remember sitting when I was doing a degree in psychology, many years after pharmacy, I was sitting in lecture theatre in third year and we're doing abnormal behaviour. And our lecturer was saying, I'm going to describe a whole host of symptoms of different conditions. And you will identify with each one, you'll say, that's me he's talking about. Guess what, he was right. He described whatever condition was and said, he's talking about me, he's talking about me. So we tend to use it's a lot of psychological effects. Chronic pain or continuation pain is pain that lasts for over 3 months. The pain can be there all the time or it may come and go. It can happen anywhere in the body. And chronic pain can interfere obviously with daily activities such as working, having a social life and taking care of oneself or others. And it can lead to depression, anxiety and trouble sleeping, which can make the pain worse. The response creates a cycle that is difficult to break. The chronic pain syndrome, theoretical definition, some noxious physical event, often no diagnosed or treatable cause. Where such pain persists, the patient may exhibit regressive changes in lifestyle. So like acute pain, you normally know what's causing that pain. You know, you smashed your elbow or you've been in a car accident or you put your finger on the stove. You know what's caused it. In chronic pain or continuation pain, generally speaking, there's no known cause. And can lead to invalidism, alterations in mood, sleep disturbances, marital upheaval. It creates massive problems when one partner is in chronic pain and the other partner is not all that sympathetic. There's nothing wrong with you. You've been to 1 million doctors. They say there's nothing wrong with you. But they are in pain. They are in pain. They're not making it up. And of course, there's social withdrawal as well. The chronic pain syndrome then is the treatment predictions must take into account the age of the individual, the physical status of the individual, characteristics and duration of pain, the history of adverse events during childhood, medication dependence, illness conviction. Again, people with there's beliefs, illness, behavior, beliefs, degree of disability related to impairment, coping and adaptive skills, interpersonal and family support systems, self-image, motivation, presence of extrinsic reinforcing factors. It's interesting with self-image, if people have a low self-image, they look at themselves, and I developed this very scientific scale. It's called the wow yuck scale. So you look in the mirror, which I try to avoid these days when I shave. Occasionally I say, oh my God, who's that old fellow? But the wow yuck scale, very scientific, is you look in the mirror and you say, ugh, yuck. Okay? And you've probably all done that at some stage or another. Or you look and say, wow. And of course, it's being very scientific, it's a continuum. And most of us somewhere in the middle and fluctuate up and down a little bit. And of course, you get to extreme. If you've got a yuck scale and you're permanently on the yuck, I love the science of this, then obviously you're much more likely to not recover from that sort of pain, the chronic pain, because you've got a very low self-image and that contributes. So there's a strong psychological component. So the chronic pain syndrome must be considered when pain has been present for several months, remains poorly localized. It hurts. Where's it hurt? It just hurts. So somewhere along there. It's very indefinite. It occurs in the absence of any discernible pathological process, remains unrelieved by routine clinical doses, standard analgesics, including opioids, is aggravated by surgical intervention, is linked to psychological circumstances, obviously, seems to serve no overtly useful purpose, unlike removing my finger from the stove. That serves a purpose, it stops the stimulant. Is often associated with gross limitation of function. And these people are in real trouble. So there is the chronic or continuing pain cycle. So you start off with the pain, whatever it might be. Yep, there we are, there's pain, and it will take one, doesn't matter, there's 2 cycles going on. So there's activity avoidance, when you've got pain, I'm too much pain to do this, that or the other. Progressive deconditioning, pain with decreasing activity, which of course is not good. Further activity avoidance, further decondition, and of course makes the pain even worse. And if you go on this cycle here, you've got pain which can cause anger, anxiety, fear, distress, impoverished mood, depression, increased perception of pain. It's a vicious double cycle. It really, very complex. It's not fully understood. So if we compare acute pain versus chronic or persistent pain, the onset with acute is obviously well defined, poorly defined in chronic. The cause, acute injury or illness, chronic response in the chronic one. Physiological, sympathetic overactivity, obviously in pain. So you're definitely in pain, you maybe a serious wound or whatever it might be, but you know about it. There's no sympathetic overactivity, that's the sympathetic nervous system, not obviously in pain. The affective is anxiety, depression, other psychological changes in this area. Cognitive, positive response to transient illness, meaningful pain. Here, of course, it lacks positive meaning. Why am I in this pain? It's meaningless pain. Behavioral, inactivity until recovery, even though these days we try to get people out and about very quickly. And in this one, of course, changes in lifestyle, changes in functional ability and withdrawn, and treatment, and in the case of acute, treatment of injury, illness, temporary use of analgesics, bandages or whatever. And in this one, treatment of underlying cause, if you can find it, regular analgesics to control pain, psychosocial supportive pain. Analgesics are probably not enough. You probably need the psychological support as well in the persistent pain. Pain assessment measures. Well, we do have some. You've probably all seen these before, many times. These can be used in children, or it can be used in people with perhaps impaired cognition. And there's various scales. This is 1 to 5, it could be 1 to 10. And you've got a smiling face, doesn't hurt, right down to it really hurts the worst. That's quite good. Because the individual is his or her own control. Because we can't take a blood sample and we can say, yes, you've got this much pain in you. We can't do that. So the individual says, I've got this pain. On a scale of 1 to 5 or 1 to 10, how would you rate it? We try a certain treatment, and after a period of time, we then rate it again. That gives you an idea of the efficacy of the treatment, be it physical treatment or drug treatment. This is the Wong-Baker-Faces pain rating scale, used of children. So this is the more common one, as a scale of 1 to 10. And you can show them that, or you can ask on a scale of 1 to 10. It's a Likert scale. You can ask at the same time about the intensity of the pain, location, the onset, the duration, the variation, and the quality of the pain. And there's all sorts of terms for that. So that is quite useful. It would be nice if we could take a blood measure, but obviously we can't. There's a new artificial intelligence pain assessment tool. Of course there is. This is very new. This is only that came out a few months ago. A new pain assessment tool using artificial intelligence and facial recognition has recently had regulatory clearance in Australia and Europe for use in pain assessment in people with dementia. And dementia, remember, is an issue where it's very hard to get information from the individual. The program is called Pain Check, uses a smartphone camera. What those phones can do is amazing, isn't it? To record a short video of the person's face and analyze images using facial recognition analytics. It automatically recognizes facial muscle movements that indicate pain and take note of them. It's then used to record observations of pain-related behaviors, such as how the person is moving and vocalizing pain, and an overall score is calculated to monitor the effects of medication treatment over time. So you get a special app, which I believe are now available, and this can be done. And there's another one. There was one other one. Oh no, that's the only one. Okay, drug options for pain, which of course is what you're probably interested in. So drug options for osteoarthritis. Probably you could say fairly accurately that anybody over 60 in our society has got some level of osteoarthritis. And of course that can manifest itself in the foot, in the toes, and any part of the body. So paracetamol is the first starting point. It's not a particularly good anti-inflammatory, and osteoarthritis, the pain from osteoarthritis is inflammation, but it can relieve the symptom. What about glucosamine and chondroitin and or fish oil? Any comments on that for osteoarthritis? No? You've heard of these, of course. Yeah. Oh, the evidence is they do nothing. Okay, except perhaps lower your bank account. And similarly with fish oil. When we come to rheumatoid arthritis, it's a slightly different story. What about paracetamol and codeine? Well, we now know that codeine is off prescription only, codeine products, quite rightly, for all sorts of reasons. People were suffering from the effects of, because you couldn't have codeine over the counter by itself, it was always in combination with either paracetamol, aspirin, or another non-steroidal anti-inflammatory drug. And so what people were buying it to get the high from the codeine, but they would take multiple tablets, and they would not suffer so much from the codeine, but from the aspirin, say, which is non-steroidal anti-inflammatory drugs in big doses, can be devastating. And of course, abuse as well. So that was a good move. Doctors can prescribe it. I don't think podiatrists can prescribe a combination of codeine at all now. Sorry, you can. Up to 60 milligrams? Do you know?
Up to 30 milligrams.
Sorry?
Up to 30 milligrams.
Oh, 30 milligrams, you get 2 tablets. And that's with paracetamol, ibuprofen. Yeah. Oh, that's good. That's good. It gives you an option. I mean, codeine is not a particularly good analgesic, but it's better than some of the others. Not nearly as good as the other opiates. Overuse with headaches, we've got that. NSAIDs plus a proton pump inhibitor. Anybody who is taking a non-steroidal anti-inflammatory drug, including aspirin, aspirin is not in a class of its own. If you like, it's the first non-steroidal anti-inflammatory drug we've ever had. But so they always put in separate class. The modes of action is exactly the same. Will actually ultimately bleed from the gastrointestinal tract. So it recommended for someone who's got to be on it long term, a proton pump inhibitor, which will actually help to relieve the symptoms. Opioids then, we've got buprenorphine, fentanyl. Oh, you've heard, of course, the story of fentanyl just the last week. Kilograms and kilograms of fentanyl were caught at the, and I mean, can you imagine people doing that? Oh, what people do? Well, there we go. Probably funded by Trump. There's a whole bunch of those we'll look at in a minute. Corticosteroids can be given intramuscularly or, of course, orally. And there's a separate talk straight after this one on corticosteroids and pain. Highlands in Synovic, that's injection weekly intervals, waiting for surgery. Antidepressants, carbamazepine, gabapentin, and non-drug treatment. And of course, you can have non-drug treatment as well as drug treatment in combination, or one or the other. Whatever works for the individual is the important thing. So there's a World Health Organization 3-step analgesic ladder. So you've got the pain, whatever it might be. You've got non-opioid plus adjuvant. So the non-opioid would be, you start off with paracetamol, it's recommended. The proper dose of paracetamol. We're talking about continuing pain. We're not talking about, I've got a headache, so you take 1 dose of paracetamol and it helps. You don't need to take any more. But if say it's some sort of arthritic pain, and then you take that, and then with an adjuvant, and an adjuvant can be an antidepressant, an anticonvulsant, local anesthetic, or bisphosphonate. The pain's persisting or increasing, you have an opioid for mild to moderate pain, and non-opioid plus adjuvant. So you might be looking at 3 different things. And of course, we don't like increasing the number of medication a person takes because all sorts of things can happen. Pain persisting or increasing, opioid for moderate to severe pain, plus non-opioid plus adjuvant. The idea, of course, we're looking at cancer pain here. It's freedom from cancer pain, but the same sort of thing applies for pain generally. Drug options, now rheumatoid arthritis, as distinct from, and I'm sure you would see a lot of patients with rheumatoid arthritis. And it's a terribly disfiguring, incredibly painful condition. Really awful, unlike the other. So we have analgesics plus corticosteroids perhaps. Fish oil, yes, the evidence for fish oil in rheumatoid arthritis is positive. Probably not by itself, but it certainly can have some effect. Not in osteoarthritis, but in rheumatoid arthritis. There's lots of trials on both of those. It is expensive, and you need to have at least about 2.7 grams daily of the fish oil. DMARDs such as methotrexate, leflunomide, cyclosporin, azathioprine, psilocybin, hydroxychloroquine, and even gold, which is rarely used these days, gold salts. Tumor necrosis factor, the alpha TNF inhibitors, all the AMABs, interleukin-1 receptor antagonists, tocilizumab in this case, and cytokine modulators, abiceptive and rituximab, and a number of others. And there's new ones coming on board all the time. When you see a patient with rheumatoid arthritis, you'll generally see someone who's taking a lot of medications, assuming they've got no other condition. Of course, that's a big assumption because they probably will have, because rheumatoid tends to develop later in life. So as we get older, and when I go to my U3A classes, which I did day before yesterday, you know, the average age would be, you know, getting in the 80s and 90s. And if you ask how many of you are taking I would assume everyone's taking at least one medication, and you'd have at least one condition, but probably more. And again, I can deviate, tell you this lovely little story. This is some years ago. I said that sort of statement. And at the end of the talk, this little lady, she was about this tall, came up to me and she looked up at me and her eyes were glinting, cheeky, absolutely lovely. And she said, "Chloe, how old do you think I am?" And I said, "Well, what sort of question is that?" So I look her up and down, and I think to myself, a healthy 70. So being a gentleman, I say 60. She says, she comes from Eastern Europe, so I'll do the accent. She says, "Darling, I am 94, I take no medications, and I walk every day, and thank you for asking," which I hadn't, "my sex life is beautiful." What could I do but give her a hug? That was just amazing. She's now, I think it's about 10 years ago, she's 104 and still going. I don't know what a sex life is like. But it's really wonderful because we have the assumption that if you're old, that you're going to be suffering from lots and lots of things. And a lot of us do, of course. And I admit to taking a number of medications, as a number of people here. What about over-the-counter products that can be used for pain? Analgesic, aspirin, well, non-steroidals and paracetamol. The paracetamol is not a non-steroidal, it's different pathways. Codeine in combination, now all Schedule 4, prescription medicine, so, okay, we know all those. Let's look for a minute at paracetamol. It's underrated quite a lot. It's an analgesic and antipyretic. It's a fantastic antipyretic, dropping body temperature, and that can actually even help with the pain. The dose, if you're over 50 kilograms, it's that much, 15 milligrams per kilogram every 4 hours, or a modified version. A maximum per 24 hours, it should be no more than 4 grams per day. And we do get people who take massive doses of paracetamol, and it is hepatotoxic, and people can die from that. But sorry.
Why don't they have that on the box with the weight? Because I think people take the wrong dose.
Yes. I don't know if you heard, but why don't they have that on the box? Good question. Why don't they have it on the box?
The weight.
Yeah, the weight, yeah. I think, well, it does when you've got the children's ones.
Yeah,
The children's one, yeah.
Not
The adult. Look, because we know, unless you're very underweight, 4 grams per day is safe. Contraindication, well, side effects, very rare, very rare. Drug interactions, pretty much. These are all minor. They don't actually cause a great problem. A colleague of mine presented this. Warfarin, 3.5 grams per paracel per week, can affect warfarin. Really, it's not an issue. You wouldn't take someone off paracetamol. That's what they needed if they're on warfarin. Now, we know that fewer and fewer people are using warfarin these days anyway. We've got the newer ones, which we'll talk about later. Newer now, we're talking 10 years. They come in 500 milligram tablets, or they come, the problem we have with something like paracetamol, which is readily available, is that you might be taking regular paracetamol for a particular condition, and then you develop a cold. You know, you've just eliminated, no, it's not COVID, I know it was going to be COVID, but the symptoms can be similar. Anyway, you've got a cold, a bit of flu, I mean, flu is not the right term, but that's what the cold and flu symptom. So they go into a pharmacy, and unfortunately it's self-help. And there's a whole range of different products that contain decongestions and a whole range of things, and usually paracetamol. So they're already taking the normal maximum dose of paracetamol, and they're adding to it. That's where the danger comes in. So people add, and again, this is where it really should be supervised by a pharmacist. But Schedule 2 doesn't have to be supervised by a pharmacist. It's in a special area of the pharmacy, and of course you can ask for help and should ask for help. I'm always telling my U3A people, ask questions. You are the customer. You go and ask questions. You're not sure how to use it. And I think it's absolutely criminal to someone walking out of a pharmacy or a surgery and has got medication either prescribed or over the counter, and they don't know how to use them. Sometimes the directions on the box is not appropriate because for that person. Remember, everyone's different. They might be taking different medications. So it's really quite important. Then we now have many brands of paracetamol modified release. So instead of taking 4 times a day, and it's essential with the immediate release, it is 4 times a day to maintain the levels. This is 3 times a day. And the reason that was developed is that many studies have shown that as you increase the frequency of doses taken per day, you increase the lack of adherence or compliance. That the people, you forget the dose, even 3 times a day dose. So the 3 times a day antibiotic, for instance, and you're supposed to take, say, 7 or 8 o'clock in the morning, about midday or 2 or thereabouts, or then the last thing at night. A lot of people forget the midday dose. I know I've done that. And it's not a lack of intelligence, I hope. Maybe in my case it would be. But generally speaking, the more complex it is, the more chances there's going to be errors occurring. And that was the idea behind it. And it's good. It certainly has a positive effect. But again, they're taking that, that's for my arthritis. Nothing to do with my cold, that I'm going to choose something here, which you can then add on more paracetamol.
Louis,
Yeah.
can I ask a question? So in comparison between sort of taking paracetamol 4 times a day or the modified release, what does the study say in terms of sort of post-op type pain or sharp pain? Is there a difference in patient?
Well, if it's just a sharp pain and you know it's not going to, you probably don't need, you might only need a couple of doses. I'm talking to someone who's going to be on continuation therapy. Then you're much better off taking the modified version, irrespective of brand now, because they're all made by the same company and repackage it and do things. It's, you know, the drug companies do all sorts of lovely things.
If we've got someone, say, post-operatively who we know will be in a bit of discomfort for a couple of weeks,
Yeah.
and they're on the modified release,
Yeah.
is it beneficial to take them off that, put them on to say 4 doses a day to get a more rapid?
Not really, no. It's interesting. I did have a slide in the past where I talked specifically about that, where they compared the sustained release versus the immediate release, and the time taken, because it's a bilayer tablet. So you've got immediate release component, so you get the immediate, you know, within 20 minutes, half an hour effect, and then you've got the slow elimination. So there's probably no advantage. Okay, non-steroidal anti-inflammatory drugs, NSAIDs. What we know, we have tissue injury, release of phospholipids, it goes through arachidonic acid cycle, and that leads to release of various things. So we've got cytoprotective prostaglandins coming from this particular pathway and inflammatory prostaglandins. So if you look at our standard or cyclooxygenase enzymes that you saw in the slide, COX-1 is involved in normal physiological functions, including the production of protective prostaglandins in the stomach, whilst COX-2 is induced by inflammation. So both enzymes are inhibited by non-steroidal anti-inflammatory drugs, or NSAIDs. COX-2 inhibitors have little effect on COX-1 activity and so do not inhibit prostaglandin synthesis, which means they're kinder to the stomach. That's really what it amounts to. So you've got the COX-1, the COX-2, or the traditional NSAIDs is COX-1, COX-2 mixture, and they will can have a dramatic effect on the gut. The COX-2 ones are much kinder to the gut, basically because of prostaglandins. So when you talk about NSAIDs, though, because they are used a lot, I've got it as a poison. Well, all drugs are poisons because it's a matter of dose. Choose your poison. Do you want cardiovascular problems? Do you want gastrointestinal? Do you want hepatic or renal effects? You probably could get any or all of these with NSAIDs. So if you look at the traditional NSAIDs, they're a mixture of COX-1, COX-2 inhibitors. You've got the aspirin and then the non-steroidal anti-inflammatory drugs, which aspirin is one anyway. And they antiplatelet in a very low dose, analgesic, anti-inflammatory, antipyretic, and then there's various doses. These are the officially recommended doses you'll find in the AMH, you should find in MIMS and all of those places. And basically their modes of action are similar. These are the traditional NSAIDs. They're COX-2 inhibitors, there's celecoxib, meloxicam, and there's a few others now. Again, they are analgesic, anti-inflammatory. Be careful with celecoxib because it's got a sulfur moiety. And if you're hypersensitive to sulfur, sulfonamides and drugs like that, then you can show hypersensitive reaction. Even when it was first released, years and years ago now, there were quite a lot of people, and then warnings came out saying, you know, have you any adverse reactions to drugs? You should always ask. The doses, of course, vary. When you're using an NSAID, when prescribing an NSAID, in your case, as you would I'm sure you do, use with caution in patients with medical history of ischemic heart disease, peripheral vascular disease and or cerebral vascular disease. Maximum response should be seen in 1 to 3 weeks, but they can work a lot quicker than that. Alert the patient to signs of gastrointestinal tract bleeding, black stools or dark coffee-coloured vomit. Caution if taking warfarin, of course. To lessen gastrointestinal complication, use the lowest effective dose and take paracetamol as an alternative. Now that statement, use the lowest effective dose, really applies to every drug. Because as you know, we have a dose range for each drug that's recommended based on clinical trials and so on. And if you're getting the effect that you want, whatever you're treating, with a certain dose, there's no point in going any further. All you're doing is introducing more potential side effects. So use the lowest dose that achieves what you're trying to achieve. And the patient feels happy about it. Check the use of over-the-counter NSAIDs, because we can buy them over the counter, and even some in supermarkets. I can't believe, but you can. Only 12 tablets. Does the patient suffer from diabetes, asthma, or peptic ulcer? Because that can affect them. What is the indication for the treatment? Why is it being prescribed? Does the patient have hypertension or heart failure? There's certainly, if a person has hypertension and they're well controlled, a short course of a non-steroidal anti-inflammatory drug, assuming everything else is okay, is not going to be an issue. But if they're very brittle and the blood pressure goes up and down all the time, you'd have to be more careful. Does the patient has no effect on platelet aggregation? An antiplatelet agent may need to be taken on medical device, for it, like low-dose aspirin. Consider stopping 2 to 3 days before planned surgery. So that could certainly affect you as surgeons. All NSAIDs cause gastrointestinal tract bleeding. When I was doing my master's in pharmacology, I had someone working next to me. I was working on adrenergic neuron blocking drugs, which we don't use anymore. That was the story of my life. And this lady was working on the effect of contact NSAIDs on rat gut. So she dissected a rat, took out the gastrointestinal tract, and put various aliquots of I think it was aspirin that she was working with, and then worked out, and of course it was all visualized, and you saw the development of ulcers. All NSAIDs will cause ulceration. All NSAIDs will cause bleeding. And of course, the longer you take them, the more chance that that's going to happen. NSAIDs may cause hyperkalemia in combination with other drugs which can increase potassium concentration, will increase this risk, honestly, potassium concentration, may increase blood pressure, I've already mentioned. Systemic absorption of topical salicylates may give rise to drug interactions. Use, well, we know what they're all used for. I don't think we need to go through that, and I'm conscious of the time now. Safety, there's a lot of issues with non-steroidals, big issues. And to have them in supermarkets is really an obscenity. It really is. But there we go. TGA outcomes, the review of cardiovascular risk associated with the use of NSAID. They developed from the Therapeutic Goods Administration and research that, well, really this is the important one, that diclofenac, naproxen and ibuprofen, these are over-the-counter ones, can cause the cardiovascular problems. All of them can. Again, the triple whammy, you've heard of triple whammy? Yeah, of course you have. Okay, so I won't go into it, but that is really important to remember. But remember, and I think this was in my undergraduate lectures to podiatry students, we talk in terms that you've got a limited number of drugs that you need to know about and you're allowed to prescribe under certain conditions. But keeping in mind, we're going to teach you about the whole gamut of drugs because you need to know about them. Because when you talk to your patient, you need to get a history. You need to know what medications they are taking, as well as what their conditions are. And that may well be you've got your favorite drug you want to prescribe, but it's not appropriate for that person because of what he or she is taking or the condition they've got in. So it's pretty important. So ACE inhibitors, NSAIDs and diuretics individually or in combination are implicated in over 50% of cases of iatrogenic acute renal failure in older people. And that's a serious condition. People can die from that. Well, we can piss that. Opioid analgesics very quickly, and of course this is the morphine structure. It's all based around the morphine structure, which comes from Paracetamol somniferum, the opium poppy. We did this in pharmacology, great stuff, wonderful. It's a fantastic molecule, and you'll see when you look at the various opiates that they all have certain parts of this molecule embedded. You may not be able to recognize it, but it's certain parts that are required. And they have different effects. So the mode of action of opioids, it's opioid analgesic act on opioid receptors in the central nervous system and gastrointestinal tract, producing analgesia, respiratory tract depression, sedation and constipation, and of course becoming addiction. They act mainly at the mu receptors in the CNS, reducing transmission of the pain impulse, and by modulating the descending inhibitory pathways from the brain right down through to the other areas. Cough suppression occurs in the medullary center of the brain. Morphine used to be used as an antitussive, of course it's not now, but it is they're all potent antitussives. Codeine tends to be still be used for that purpose. The affinity of individual opioid analgesic for receptors varies, and opioids may act as pure agonists or partial agonists. Partial agonists demonstrate a ceiling response above which an increase in dose does not produce an additional increase in effect, and that's important. This is examinable, by the way. So there we have morphine. So there's the parent structure, which comes from natural sources. And of course, I'm sure you've heard natural is good, synthetic is bad. I don't take chemicals. And then you say to people, excuse me, but we are all chemicals. Everything in the world is chemical. So it comes from natural sources. It must be safe. Of course, we know that's rubbish. It just depends on the actual compound. The interesting thing, and you can see many of them look very, very similar. And we've got oxycodone, which probably is the most commonly used opiate, legitimately used opiate. God knows, got people taking illegally a whole range of stuff. And there's a whole bunch of them. And they've got varying levels of effectiveness. And you've got an antagonist there, methadone. And when you've got an antagonist, is this methyl group here on morphine. If you've got a larger group, it makes it an antagonist. So there's a whole bunch of these, and methadone, of course, is used in methadone program, as you know. Fentanyl is probably, and you mightn't recognize that as an opiate, but if you look at the particular active points to it, it's got the particular molecular structure that has the effects on the mu receptors and other receptors, but the mu being the ones. And that, of course, is the most potent of them all. So where am I? Here we go. So precautions, taking drugs that cause central nervous system and respiratory depression. People who die of overdose or are very sick due to overdose are going to die or be very sick from respiratory depression. And of course, taking drugs that cause CNS benzodiazepines included. People might be taking a benzodiazepine, given an opiate, and you get additive effect on the CNS depression, the CNS and respiratory depression. Comatose patient, contraindicated, except when used in terminal care. Uncorrected endocrine abnormalities, hypothyroidism, adrenal corticoid insufficiency, acute alcoholism, myasthenia gravis, CNS depression, careful dose titration is required. Epilepsy or recognized risk for seizures, head injury, metabolic disorders, alcohol and drug withdrawal, CNS infections can all cause risk of seizures. Now some people, very rare, but some people have what we call the feline reaction to opiates. If you give a dose of an opiate to a cat, it will, instead of being slowing and going to sleep and being happy and purring, it'll be running up the walls and hitting its head on the ceiling and falling to the floor, and often will just drop dead of a heart attack. That's rare. And it's not rare in cats, but it is rare in humans, and it's called the feline reaction. That's a very rare thing. Precautions: raised intracranial pressure, hypotension, shock, reduced blood volume, a whole range of stuff. Pheochromocytoma, the risk of pressor response due to histamine release. Morphine has so many actions, many actions. Adverse effects: type and severity of adverse effects depend on dosage, circumstance of use, acute or chronic pain during anesthesia. Adverse effects may limit achievement of adequate pain control, and options for management include controlling symptoms, reducing the dose of opioid and possibly adding non-opioid or adjuvant analgesic. And again, I might have told you this story, but a colleague of mine, Jenny Gowan, who's a good friend, she comes from New Zealand, and her father was dying. She's a pharmacist as well and does a whole bunch of lectures for different places, and then she was involved with the podiatry course at La Trobe with me. Her father was dying of prostate cancer, and she flew to New Zealand, and he was 94, 96, something like that, and he was in extreme pain, and they had him totally comatose. The pain was totally controlled with morphine. But of course he couldn't communicate with his wife or his daughter. So Jenny suggests, can we not reduce the dose of the opiate and add paracetamol? You know, little paracetamol you can buy anywhere. And they did that, and a day or two later, he was still in pain, he was in a lot of pain, but he said, I can talk to my wife, I can talk to my daughter. It was only a few days ago. So adding something like that enables you to have a lower dose of the opiate. It can be quite effective. Now, that's a study of one, but there have been lots of studies beside that. Adverse effects are infrequent, and this is standard that you will find in the AMH, the way they describe adverse effects. Infrequent, well, firstly you've got common, and didn't I had common, oh, there were common. Greater than 1% of people who take opiate will show this, and nausea and vomiting, very common, dyspepsia, drowsiness, dizziness, headache, orthostatic hypotension, itch, dry mouth, myosis, urinary retention, and of course constipation, guaranteed constipation. Infrequent ones, that's 0.1 to 1%. The dose-related respiratory depression, it is dose-related. Bronchospasm, confusion, hallucination, etc. I won't go through them all. You've got that in your notes. The rare ones, less than 1%, SARDH, anaphylaxis and seizure. Okay, the drugs, these are the particular drugs that we've got. Now, they're not all available to you, obviously. Buprenorphine, codeine, fentanyl, hydromorphone, methadone, and the benefits we see with buprenorphine, it's sublingual tablets, transdermal patches, and so on. Obviously, these are I think, I'll just leave that table with you. You've got it, you can look at it if you need it. I think just one important thing, if someone is taking a patch, and the patches are very effective because you've got very, very good control of the release rate compared to an oral dose. Because all sorts of things happen in the gastrointestinal tract, and we're all different. But the skin, we can work out the mathematics, and you can work out there's going to be so much going through. But if they've got a patch on, and they're suffering from pain, and they get into bed and they put the electric blanket and they say, this is so nice. Yes, exactly. What did you say? No, they won't burn. No, but there's a simple, but they could. The simple law of mass action: as you increase temperatures, you increase the rate of transfer across. And people have died from overdoses of a patch, of an opioid from a patch, because they've just had the heat on very hot. So the warning is: do not use electric blankets, do not put water bottles on there, hot water bottles and so on. Simple thing like that can save lives. It's not big science, really, really important. I won't go through all these, that's the tables go through. There's quite a few, as you can see. A very useful table, actually. The equal analgesic doses of opioid, they obviously are a difference in efficacy. And that's the important thing. And duration of action is important. And if you look at buprenorphine, it's 800 micrograms taken sublingually, compared to codeine. To get the same benefit, approximately, you need 200 milligrams of codeine. You probably haven't seen doses of 200 milligrams of codeine. But that's the sort of comparison. Fentanyl, only 100 micrograms. Thousandths of a milligram is a microgram. You couldn't see it. It's so small. Hydromorphone, 6 milligram, and so on. And generally speaking, morphine is 30 milligrams. So 30 milligrams of morphine is equivalent approximately to 800 micrograms of buprenorphine and so And so you can do transfers, and the duration of action, of course, is important, depending on the dose form that you've got. You've got sublingual, you've got oral tablets or liquids, and of course you've got parenteral, not used that much these days. Pethidine we hardly use now, it's gone. It's got too many problems. And now, you've heard of Targine. Targine, I'm not sure if there's any other brands now, but this slide really exemplifies my love of affair with chemical structures, molecular structures. So here we've got morphine, typical morphine molecule. And here you've got, that's oxycodone. And you've got naloxone, which is oxycodone, but the only difference really is, almost the only difference, is this methyl group has been changed to an N-ethyl group. And that makes it an antagonist. And so this combination is most of the problem. One of the big issues, I said, I can guarantee you'll get constipated if you take an opiate. I'm almost done. What this causes are the receptors in the gut, and naloxone does not get into the central nervous system at all. Whilst, of course, oxycodone does. That's where you want it, to relieve the pain. So it doesn't affect the pain relieving abilities of the oxycodone, but it reduces the serious constipation effect. Doesn't work for everybody though, that's the trouble. It can be very good. And you can use palliatives and things. Opioid dosage, well, I think you can increase the dose. Tapering dose is always an important thing. Don't stop suddenly. There's a whole bunch of different practice points which you can look at your own, and I think it's a good time to say thank you and to, what are you doing, having a break? You want to go straight